New studies released by the CDC yesterday and by New York State on Monday further complicate the debate over how to best protect children during the COVID-19 pandemic. CDC data shows that among 12 to 17-year-olds, protection against hospitalization offered by being fully vaccinated dropped as much as 21% after the 5-month mark, whereas officials in the New York study, which is not yet peer-reviewed, found a much more dramatic waning effect. In 5 to 11-year-olds, vaccine effectiveness plummeted 68% down to 12% during the Omicron wave. Protection against hospitalization dropped from 100% to 48% during that same period.
Joining us now to dig more into this research is Dr. Amesh Adalja. He's an infectious disease expert and senior scholar at the Johns Hopkins Center for Health Security. Thank you for joining us, Doctor.
Thanks for having me.
So what do you make of this new data? Obviously, there's greater resistance in some places to vaccinating or having vaccine requirements for kids. And, we're weighing a kind of different risk calculus because we know that kids are not at as great risk of a serious negative COVID health outcome as older Americans. So if this is showing that there's even, not that much durable protection, then, how should we interpret that information and how should that inform our policymaking?
The best way to interpret it is to try and take a step back and think about what we're trying to achieve with the vaccines. And that's protection against serious illness, hospitalization, and death. And while there may be dramatic percentage numbers and drop of effectiveness against any infection or ER visits, there's still robust or significant protection against severe disease. And children tend to be spared from severe disease, but in those high-risk children, this is still a safe and highly effective vaccine. And you also have to remember that some of these studies occurred when Omicron was dominant. And Omicron is an immune-evasive variant of the virus, and it erases a lot of the protection against mild disease that vaccines provide. And the last part of this is just remember that children between the ages of 5 and 11 get a lower dose than children 12 and above. They get about a third of the dose. So that also may be playing a role in the effectiveness numbers dropping off in that age group.
And President Biden last night during the State of the Union talked about the potential of kind of 0 to 4 getting approved, and he talked about it as an if and when situation. What's your latest understanding around the science on that question?
This vaccine is shown to be safe in the 6-month to 4-year-old group. It's just about getting the dose right. And when they did the study, when Pfizer did this study, they saw that the low dose that they were using, and this is even a lower dose than they use in the 5 to 11-year-olds, this is a 3 microgram dose, it seemed to work in the 6 months to 2-year-olds and gave the amount of antibodies that you would expect. But in that 2 to 4 age group, it seemed to not be as immunogenic. And because they've already started this trial with this lower dose, they're adding a third dose to see, does it boost up immunity? So I think that we'll eventually get there. It's going to be delayed, but we want people to have confidence in the process that the dose that the child is getting is going to be right for that child, and it's going to be effective. So I think we still have to hold on, but I think when you think about where the risk factors for severe disease is, as you get into that younger age group, it becomes less and less likely that COVID your problem for them. Because everybody above the age of 5 can be vaccinated. This is a small group that we're trying to get vaccines for. But in general, in the trajectory of the pandemic, it's not going to be those 0 to 4-year-olds that are compromising hospital capacity. And I think we have to really prioritize where the vaccine is most important. And that's still in those adults that haven't been vaccinated yet.
Yeah. I know a lot of parents, I think when they're weighing the vaccine decision for their kids, maybe it's very easy decision to make to get the kid vaccinated if they are immunocompromised, if they're obese, if they fall into some kind of risk category. But other parents are maybe having a more difficult time if they have a child who does not fall into one of those categories, and they're concerned about. We hear about myocarditis for one. Obviously very low rates of that, but also low rates of hospitalization anyway from COVID among kids who don't have an underlying health condition. So does this change that calculus any further than that?
Well, I think anytime you're looking at a different age group, you have to do a specific risk-benefit calculation for that age group. And I do think that the fact that Omicron appeared and made our vaccines less effective against any infection is going to be something that parents have to weigh because, yes, children are spared from severe consequences of disease. But I would argue we vaccinate for things like chickenpox. We vaccinate for diseases like rotavirus, which don't really have a major mortality or morbidity impact on children. But yet we do it because we want to avoid the child avoiding this inconvenient illness that puts them out for a couple of days that could be contagious to other people. And I think that's the best way to think of COVID-19 vaccines. And when it comes to myocarditis, it's usually not those small children that we're worried about. It's people that are in their late teens into their early 20s. So even though people think about myocarditis a lot with children, it's more in that older age group, especially males. And there's ways to mitigate that by perhaps spacing dosing of the 2 doses of the Pfizer vaccine in children, which there is evidence for. So I think this is all something that you can talk to a pediatrician, you can talk to an infectious disease doctor, and parents can kind of reason their way through this decision. But I think it is important to do those risk-benefit calculations. And in the end, I think the vaccine still comes out far on top.
Yeah. And that's also something that Sanjay Gupta recommended in his interview with Joe Rogan, where Joe Rogan kept pushing on myocarditis. He said, if a parent is really concerned about myocarditis, one thing they can do is spread out the time between the 2 shots, or just take the one shot.
Or forego the second shot, right?
And forego the second shot. So that was Gupta's kind of informal general recommendation, drawing on some of the science that you just pointed to. Why is it that hasn't been more formalized in the way that we think about this, and why is Pfizer clinging to the 3 weeks that runs between the 2?
So this is because when you apply for emergency use authorization or approval from the FDA, you have a certain dose, you have a certain dosing interval, and that's all they're allowed to market. That's all they're allowed to actually say, because that's what's on the label. But we are seeing the CDC move on this. The CDC is saying some people can wait 8 weeks. And I think what happens often with public health agencies is they want a one-size-fits-all type of solution. And one-size-fits-all doesn't always work, because what we want to be striving for is precision-guided medicine. And I think increasing that interval is something that many of us advocated early on, because yes, it decreases side effects, and it also probably makes the vaccines better, makes them more effective, because the immune system gets a better boost from that second dose, having it farther out. So this is something finally that the CDC has started to embrace, and there is guidance for doing this, but it is definitely something that will help with vaccine hesitancy when people are worried about myocarditis, because it is that second dose that's more important when it comes to myocarditis, and you can just space that out, or even forego it, because one dose does provide some level of protection, especially in younger children who are at low risk for severe complications.
Yeah. What is the hope, for the future to combat potentially new variants that come along? Would we always expect a variant in the future to be in the mold of Omicron, which is increasing the infectiousness, but less of a footprint in terms of severe disease and death? And do we have to look at changing our vaccines, right, or updating our vaccines to keep pace with the reality of whatever COVID mutates into?
When it comes to respiratory viruses, they generally are favored by evolution to become more transmissible and less severe, because it really favors transmission if people are out and about, going about their life and infecting other people. So we don't usually see more severe cases of a disease evolve. It's usually more ability to evade vaccines or to evade natural immunity and become more transmissible. That's the most likely scenario. And when it comes to vaccines, what we know is that the vaccine that's targeted against the ancestral strain of this virus is still working against what matters, even with Omicron, preventing severe disease, hospitalization, and death. So it's unclear to me yet whether we need to update these vaccines. I think we have to keep abreast and have a lot of situational awareness of what's going on with variants, what's going on with vaccine efficacy. But it's too early to know what the optimal vaccine policy may be. And there also are second-generation vaccines that you haven't really heard much about that are making their way through clinical trials that also may change how we think about vaccine policy for COVID-19 in the future.
Yeah, what are you hearing about the non-mRNA vaccines, the more traditional ones? Because there's a huge subset of people who are just kind of spooked by that technology, and if there was something more traditional along the lines of a measles vaccine, might be less reluctant to take it. How close are we to something like that?
In other countries, for example, they do have inactivated traditional vaccines that are available, and some of them have applied for approval through the FDA. We also have both Sanofi Pasteur and Novavax vaccines, which are making their way through FDA. And remember, the Johnson & Johnson vaccine is not an mRNA vaccine, so people can use that today. That's already got emergency use authorization. But I think this is going to be important to have a big portfolio of vaccines. They may be more appealing to certain people who are less likely to get an mRNA vaccine, less likely to get the J&J vaccine, but they also may be important for mixing and matching strategies, optimizing boosters. All of that's going to be really important as we try to control COVID-19 in the future, as it becomes more of a routine illness and a routine vaccination.
Dr. Adalja, thank you so much for joining us. We appreciate it.
Thanks for having me.
More Rising right after this.